has spine infection, they need a diagnosis by needle biopsy, blood culture, whatever it is, find the organism and put them on antibiotics and get them well treated, and they'll do fine. If you don't do that, they'll come to me with a raging infection, epidural abscess, and they aren't moving their legs, then it's no longer a medical problem. Then I have to get involved, and I've got to go in, do the decompression, reconstruction, whatever it may be, then it becomes a huge problem, and you may not get the neurologic function back, okay? So if any of you guys are out as PCPs out in the world, if you have an elderly patient and they have back pain, they have diabetes, they're immunocompromised, whatever it may be, and in the elderly population, they're all immunocompromised, right? So be careful in not missing your lumbar spine infection, because it's easy to treat with IV antibiotics, but if you don't catch it and they get advanced, then it becomes truly a nightmare of a problem to treat. And it's becoming more and more common as we have an increasing number of elderly patients. Metastatic cancer of the lumbar spine. As we have very excellent cancer treatments, people are living longer with their cancer, we're seeing more and more of the metastatic disease to the spine. This is also a problem if it is caught late and they come to us with neurologic deficits. I've got to go in and I have to remove all of this because there's so much canal compromise, compression, and they'll have neurologic deficits, and then it becomes a huge problem in somebody that may have a very short lifespan, right? So if we're able to catch these earlier and are able to treat them other ways, kyphoplasty is a very good procedure for compression fracture from pathologic fracture from metastatic cancer. And certain cancers respond very nicely to radiation treatment. Multiple myeloma, very common metastatic cancer of the spine, is very easily treatable with radiation. So again, don't miss your metastatic cancer and try to treat them before they get this bad where they need extensive surgical procedure. Oh, sorry. That was actually spine infection I messed up. But this is the metastatic cancer, where it's multiple metastatic cancer spread throughout the spine. And then lastly, this is also probably very common in our elderly population. Just a pure compression fracture. Boy, I see like 2 or 3 of these a day when I'm on call, right? So the literature out there about kyphoplasty has actually been very bad lately. There's been an international publication suggesting there's no difference in outcome with kyphoplasty versus conservative care. And I will agree with you, if you come to me and you have mild pain from a compression fracture, you don't need kyphoplasty. But I will tell you, the elderly patients that has a hip fracture can't get out of bed and will be dead in 3 months, it's the same thing in a compression fracture if you can't get out of bed. So if you have a compression fracture in your patient and they're miserable and they can't get out of bed, kyphoplasty is a very good procedure for it and can get them out of bed so that they don't get all the attendant problems associated with being bedridden from that fracture. All right. So I think I covered some of these. These are some of the more common problems that I run into that you probably also see in your patient population. Of all of these, I think the spine infection and the metastatic cancer, if all caught early, are good medical problems, and try to keep it that way. If you have spondylolisthesis and you're symptomatic, it's a very good surgical problem. If you have lumbar spinal stenosis and you have neurogenic claudication, very easy surgical treatment and very good outcomes. Now, lumbar compression fracture, if there's a very difficult pain and you can't get out of bed, kyphoplasty is a very good alternative and it's very successful in getting these patients well treated. Okay, I'm almost done. This is my last slide. I want to cover one thing. I review a lot of medical malpractice cases, and I would tell you in the lumbar spine, about a third of them are about cauda equina. Okay? And I don't know how many of you guys actually will be in the front line and seeing this stuff, but please do not miss cauda equina syndrome, because that is neurosurgical emergency or a spine surgical emergency. So let's go over that a little bit. What is cauda equina syndrome? The cauda equina are the nerve roots that come off the conus that's in the majority of the lumbar spine canal. It comes from lumbosacral nerve root compression. You'll have back pain, you'll have leg pain, and you'll have saddle anesthesia. You could have leg pain, back pain just because you have disc herniation, you have lumbar spinal stenosis, right? So it can overlap and it can confuse you. But saddle anesthesia is very unique. It is very unlikely you'll have saddle anesthesia with a sciatica or neurogenic claudication. And then if you have urinary dysfunction, which is hard to diagnose because everybody who's on pain medication can't pee very well. So it's hard to pick that one out. But if you have urinary dysfunction and your post-void residual is greater than 100, something's not right. So don't miss this, especially if they have silent anesthesia, and make sure you get them to the right person, because this can turn into neurosurgical emergencies, and there are patients I've had to take out stuff in the middle of the night that just have to cath themselves for the rest of their life because it just took too long. So just remember that this exists. Don't miss it in your clinical practice, and know that it can be caused by a lot of different things. It's not just, it can be caused by lumbar disc herniation that's very large and takes up the entire canal. It can be caused by epidural abscess, tumor, fracture, and even chiropractic maneuvers. So if you have somebody who's got a very large disc herniation and they don't want surgery, that's not the patient you want to send to a chiropractor. Because there has been a case or two I had a review where the chiropractic maneuver may or may not be directly associated with the cauda-equina syndrome that developed, but it occurred after they had chiropractic treatment. And I would assume if there's manipulation of the spine that you can cause more disc to herniate out as well. Anyway, so I just want to cover that so that it's one of the things you want to keep in mind and not miss in your clinical practice. Okay? Yes? Sure. Sure. So laminectomy, the nuances of spinal surgery is that the compression can be in the middle or out to the side. So in the middle is laminectomy. Out to the side tends to be out into the foramen where the nerves come out. So we call it foraminotomy, but the foraminotomy involves removing part of the facet and removing right up to the pedicle and making sure the disc disease is treated as well if need be. So a laminectomy should include, if you want to do a really thorough job in someone who's got both central and lateral stenosis, to be out to the pedicle and capture some of the facet joint. But sometimes when it's just central stenosis, and that's a rare patient, but if that's all it is, then it's just pure laminectomy and you leave the facets alone. It's when you start bugging with the facets, that's when you worry about instability and you start thinking about fusion. So then you will put some screws in. Right. So I'm operating on more and more older patients. So I think 80-year-olds now young in my patient population. And there have been a few 90-year-olds where I've had to do discectomies or lumbar spine surgery. But yes, there are certain age limitations, but it's more, not so much age, it's the patient's morbidity. There are certain patients that are 80 that are actually 60, right? So we are doing a lot more surgery in 80-year-olds, but there are some times when I look at the patient and say, my God, you're much older than your stated age, and you have so many medical problems, it's really hard. And however, when they come to me and they're just at their wit's end, we just have an honest talk and say, you may be horrible after this, not because of my surgery, because you get wound breakdown and a heart attack and stroke, all this other stuff. Because we've just gotten better at it. I mean, our anesthesiologists are better, our medical care is better. We can carry these guys through and get good results. So it's not impossible. It's just harder, but I guess we got to get better because it's become more and more frequent. Yes. 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 So the trick of the game is, where is the pain coming from? If you come to me with an L5 radiculopathy, it's not coming from L3-4 stenosis, even if you have that. So we should be trying to treat your symptoms. So, and if you only have it on one side, I've taken 80-year-olds that have one leg pain, that have multi-level stenosis, and just do one side decompression, because I just want your leg better. That's all you wanted, and so I try to limit it to that. So you don't always have to operate on everything that's there, and you shouldn't for the most part.
Do you do nerve conduction velocity EMG before doing surgery?
I do not, and it's for the following reason, is that I don't seem to get good information from that. Most of the time they come back normal, and my patient's like writhing in pain. And so I typically do not do it, but I use it in the OR to help me with my surgery, to try to make the surgery more safe and in terms of especially instrumentation. But I rarely do preoperative EMG nerve conduction velocity studies. They don't seem to give me the information. The negatives are usually not helpful. So I don't do them very commonly. No, as I said to you, I think your best spine surgeons at Tri-City are your orthopedic spine surgeons. I think they're an excellent bunch. And so I think that you can have very poor neurosurgeons who do spine surgery that do it very poorly, and vice versa. The great orthopedic surgeons that do a good job. So in my world, I've seen both kinds. I've seen guys that are orthopedic spine surgeons that are outstanding, and so I don't think that, I wouldn't tell you that we have a monopoly on the world of spine surgery and we're any better than the other guys. We certainly do more around the spine and nerves, and we do intradural work, we do tumors, and so we're maybe more adept at it in that way. But I think the orthopedic spine surgeons do so much more instrumentation and more adept at that maybe they have the advantage over us from that sense. Yeah. Yes?
What do they mean by minimally invasive spine surgery?
Yeah, so I was going to take some time to talk about that, but minimally invasive spine surgery is both, there is a true minimally invasive spine surgery, let's say movement or surgical procedures that can be called that. But it's also become almost a sexy catchphrase just to get your name out there and publicized. So you got to be, there's a mixture of that, as with anything. But what we're realizing is in any field, and laparoscopic surgery is one of them in the general surgical world, we're realizing we can do things with smaller incisions and instruments that help us do that. So now, the world of spine surgery, there's a lot of development going towards smaller incisions and getting to the pathology and working only on the pathology. However, not everyone is an MIS candidate. There's some candidates that just need open procedures. So MIS surgery shouldn't be applied to everybody, but there are certain pathologies that are very good for it. If you have one level disease and you have spondylolisthesis, you're a very good MIS candidate. If you have multi-level disease and need many more levels of procedure, you're not a very good MIS candidate.